Hello and welcome. My name is Dr Hannah Rosa. I'm a GP working in the northeast of England and a member of the GPnotebook education team. Today in the GPnotebook studio, I am very honoured to be joined by Dr Will Hinchliffe, a consultant in Renal and General Medicine working in the northeast and North Cumbria.
Hi Hannah, it's fantastic to be able to join you today.
It's great to have you here, Will. This is the first of two podcasts in which we'll focus on chronic kidney disease. Today we're going to discuss identification of CKD by looking at which people are at risk, how we test and diagnose it, and lastly, who needs a referral to secondary care. In part 2, which will be released next month, we're going to focus on the interventions for CKD that we can initiate in primary care. At the end of each podcast, we'll also have a quick quiz for you. So, to start us off, I thought that it would be a useful reminder to discuss who is at risk of CKD, as I think that in primary care, we instantly, almost as a reflex, consider CKD for our patients with diabetes and hypertension, but who else is at increased risk?
Yeah, great question, Hannah. Along with diabetes and hypertension, cardiovascular disease and obesity are the 4 key clinical risk factors. Other groups who are also at risk include those with a previous episode of acute kidney injury, those with a family history of end-stage renal disease or hereditary kidney disease, and those with structural renal disease such as recurrent calculi or prostatic hypertrophy, and people with multisystemic diseases or those with lupus, for example, those with gout, or those where there's been an incidental detection of hematuria or proteinuria that needs more workup.
That's quite a list. And I think here that it's easy for some patients to fall through the net. For example, those with a family history of kidney failure. When assessing cardiovascular risk, I routinely ask patients if they have a family history of angina or MI in a first-degree relative under 60. However, I can't recall the last time I asked a patient if they had a family history of kidney disease. Is there a strong genetic basis for CKD?
Yeah, CKD can run in families. For example, autosomal dominant polycystic kidney disease, which is due to a single inherited gene mutation. However, all-cause cystic kidney disease accounts for less than 10% of cases of CKD, so this is a rarer cause.
Okay. I've also been wondering, as increasing age is a risk factor for CKD, is there a certain age at which we should start routinely testing for CKD?
The simple answer is no, not routinely. Serial EGFRs of less than 60 are never normal, despite all of us losing 1 to 2 mils of kidney function every year beyond the age of 40. It's important to remember that being elderly is a risk factor for acute kidney injury, as EGFR is falling and CKD is more likely as cardiovascular disease and its arterial risk factors become co-prevalent.
And are there also certain medications that put people at increased risk?
Yes, especially calcineurin inhibitors, otherwise known as CNIs, for example, cyclosporin or tacrolimus, as well as lithium and long-term non-steroidal use. All these patients should have an EGFR measured at least annually. However, those on CNIs and lithium should be getting their drug levels checked, and with them, their use and ease more frequently.
So when we do medication reviews, if a patient's taking an NSAID regularly, we should check that they're having at least annual use and ease.
Yep.
Okay, so we now have a clear idea of who's at increased risk. Let's move on to discuss which tests we should be doing. Now, I feel that I should add here that NICE don't advise testing adults for CKD based on age or obesity alone. For people who have any of the other risk factors for CKD that we've mentioned, then we should measure an EGFR and a urine ACR. If we take each of these tests in turn, firstly, EGFR. This test always reminds me of a picture of a bodybuilder that we were shown in medical school who had a low EGFR but normal kidney function. And then a second picture of a frail elderly person with very little muscle mass who had a normal EGFR but very poor kidney health.
Yes, it's important to remember that EGFR is an estimate. The E stands for estimate, which is based on creatinine, and so it can be affected by muscle mass, especially in those with muscle wasting. EGFR can be estimated using serum cystatin C rather than creatinine in these types of patients, but it's analysed in Manchester. So a swifter estimate would be to use Cockcroft-Gault rather than what is CKD-EPI equation, which is available on all the calculators and often built into System 1 or EMIS, to work out the creatinine clearance, as this considers weight and height.
And hence why we need to use creatinine clearance rather than EGFR when dosing DOACs. I presume that also looking at the trend in EGFR is going to be important.
Yes, and for those with reduced muscle mass, one tip is that if the EGFR is greater than 90, we can use an increase in serum creatinine concentration of over 20% to infer that there is a reduction in kidney function.
Okay, that's useful. Following NICE CKD guidelines, we should then confirm a new finding of a reduced EGFR result of less than 60 in an adult by repeating the test within 2 weeks to check if their renal function is deteriorating rapidly, and then if it's stable again after 3 months. And if it remains less than 60, we can make the diagnosis of CKD. Another thing that I've heard, but I'll admit I don't do, is that we should advise people not to eat any meat in the 12 hours before the blood test. Is this something that you tell patients?
Not typically, as you just want them to come. Any opportunity is better than no opportunity and putting patients off. If there is doubt as to the validity of a test, then renal advice and guidance could be sought.
For our next test, urine ACR, following the NICE CKD guidelines, they advise that if an initial ACR is 70 or more, then there is no need to repeat it, but that we should recheck a urine ACR of between 3 and 70 with an early morning sample to confirm the result. Can I ask, why is it recommended that it's an early morning sample, and how important is this?
Yes, Hannah, guidelines are ideal, isn't it? Early morning urine for microalbuminuria isn't an absolute must. Once it's abnormal, it tends to stay abnormal. It doesn't regress to normal. However, in theory, this early morning sampling is to negate false negative abnormal microalbumin ratios due to over-dilute urine from individuals who consume high volumes of water during the day.
Okay, so once we have got our test results, if over 3 months the EGFR remains below 60 or the ACR remains above 3, we can then diagnose CKD. NICE in their guideline have a table which categorises CKD. Based on the EGFR, there are categories G1, G2, G3A, G3B, G4 and G5. And based on the ACR, there are categories A1, A2 and A3. Based on both categories, a person is then deemed to be at low, moderate, high or very high risk of adverse outcomes. NICE also have a second table which guides us as to how many times a year a person should have their CKD monitored. As a minimum, for example, a person with an EGFR of 50 and an ACR of 2 has CKD G3A1, is at moderate risk and should be monitored annually.
Yes, and here I'd just like to add that as well as making a note of the results, we should also stop and think about the cause, because CKD isn't a diagnosis itself, it's caused by something. It's a staging, particularly if the cause may be treatable. For example, if it's possibly due to prostatic hypertrophy, further investigations or treatment may be needed based upon the history and examination. Also, review the patient's medications and check if they are using any over-the-counter medications such as non-steroidals.
Yes, very important. And this will also cause us to think if we can optimise a patient's care in other ways. For example, by starting preventative treatment for gout or improving glycemic control for those with diabetes. Something which historically we haven't been very good at in primary care is counselling patients that they have CKD, which is shocking when you stop to think about it, and something that I believe we are getting better at.
Yes, Hannah. There are now a growing number of resources available to help with shared decision making and counselling, such as the Kidney Failure Risk Equation website, which has these resources that is freely accessible to the public. But if patients are better informed, then it can help with their motivation to make positive lifestyle changes. And if their understanding of why medications should be taken and which ones to avoid is clear, there are some excellent online patient resources available from Kidney Research UK as well.
Super. I'll pop a link to those resources in the show notes. So now we know who is at risk, how to test, diagnose, and monitor CKD. The last big topic that I'd like us to cover is referral. Now, the first referral criteria that NICE list is offering a referral to patients who have a 5-year risk of needing renal replacement therapy of greater than 5%, measured using the 4-variable kidney failure risk equation. Now, I'll be honest, I had never previously heard of this. Will, could you please enlighten us as to what this is?
Yes, thanks, Hannah. The KFRE equation considers a person's age, sex, EGFR, and albumin to creatinine ratio, and then tells you what the patient's risk of progression to end-stage renal disease is within 2 or 5 years. So end-stage renal disease meaning dialysis or necessity for transplant. NICE advised that if the 5-year figure is over 5%, then a referral should be considered. An online free access tool is available, which we've already alluded to, and I believe that this is built into System 1 and EMIS for ease of use during clinical consultations. However, remember that most patients with CKD will die of other causes before they ever need to be considered for dialysis. And so when you encounter an elderly patient with other comorbidities that are life-limiting, it may be wise to calculate their risk of death from other causes before doing the referral. And again, an online calculator can contextualize this and is available at CKDP risk, that's Prognosis Consortium risk, and that is available on the resources section, which will help with shared decision making, especially when quality of life is in sharp focus.
2 useful tools. Thank you for sharing those. So, we are to consider a referral to a renal specialist if a patient's 5-year risk is above 5% for needing dialysis or transplantation. Who else should we be referring to the renal team?
Yes, as you'll note, the KRFE is an adynamic test because it doesn't consider the rate of kidney function change, so we've not got that perfect tool yet. So we should also consider those where there's been an EGFR drop of 25% or more, or a changing CKD category within 12 months, or if they've got a sustained decrease in EGFR of 15 mils or more per year. A referral should also be considered if the urine albumin to creatinine ratio ACR is 70 or more and less known to be caused by diabetes and already appropriately treated. And we'll talk more about interventions in the next episode. Also, when the ACR is over 30 with ongoing hematuria, dipstick hematuria, although remember that hematuria without proteinuria usually warrants investigations for urinary tract malignancy, particularly in those over 60 because of the risks rising. Referral is also worth considering for those with CKD and hypertension that remains poorly controlled despite the use of 4 agents.
Yes, here I'd just like to flag up the blood pressure targets from NICE. So in adults with CKD and an ACR under 70, then we're aiming for a clinic BP of less than 140/90. And for those with an ACR of 70 or more, then the target is under 130/80. Anyone else that we should be referring?
Yes, patients with a known or suspected rare or genetic cause of CKD, or if they have suspected renal artery stenosis or recurrent renal calculi, also merit consideration. However, these things, particularly the former, are not common, and patients should mention, hopefully, that they have a relative on dialysis, for example, to give you some clue that this is something perhaps hereditary. Also remember that CKD can cause anemia, so if a patient has a hemoglobin of less than 10 and has a GFR less than 30, stage 4, ESAs, so erythropoietin stimulating agents, and or intravenous iron may help quality of life. And finally, the last group, in those who have had a previous episode where serum potassium has breached 6, this was because CKD is very likely in this group because they have reduced restrictive capacity. So, for example, people on MRAs, RAS inhibitors with heart failure, around 50% of those might have some underlying CKD that's just not being coded.
And with this last point, is it also because management will be trickier? So starting an ACE inhibitor or an ARB could result in further hyperkalemia.
Indirectly, yes. But it's also an opportunity for meds optimization and the potential exploration in potassium binder use, which is NICE approved. It's just not been widely embraced, perhaps just due to insight and perhaps cost and concordance amongst the NHS patients. And it's worth saying that a urgent referral or discussion may be needed if the eGFR is less than 15 or if there is acute kidney injury. If there is suspected nephrotic syndrome, where you get heavy proteinuria and a low serum albumin with swelling of the limbs or face, or if there is a hypertensive crisis or suspicion that a systemic illness such as myeloma has kidney involvement.
Thanks, Will. Lots of great advice there that will help us all in improving our skills at identifying CKD and knowing who would benefit from a referral.
You're welcome. Thanks for this opportunity. I'd just like to add that there is a really helpful resource for primary care on identification of CKD, which is available from Medscape, which I've co-authored with 2 GP colleagues who are passionate about cardiovascular and CKD optimization. And our aim was to make it as simple as possible. So it's a 1-pager, and your table for monitoring and risk modification is all in one place, as is suggested referrals. So thanks very much.
Great, I've added the link for this into the show notes. Now, as promised, it's time for the quiz. Question 1. What are the 4 key clinical risk factors for CKD? The answer is hypertension, cardiovascular disease, diabetes, and obesity. Question 2. Mary is a 70-year-old lady with hypertension. Her blood tests show that her EGFR is 85 and her urine ACR is raised at 4 on 2 samples 3 months apart. As Mary's EGFR is normal, she doesn't have CKD. True or false? The answer is false. If either the ACR is raised at 3 or more, or the EGFR is less than 60 over a period of 3 months, then the diagnosis of CKD can be made. She has CKD G2A2 and should be monitored with yearly kidney function tests as a minimum. Question 3. James is 30 with type 1 diabetes. His kidney function is stable with an EGFR of 42 and an ACR of 2, giving him CKD G3BA1. He has a 5-year risk of progression to kidney failure of 2.2%. Based on this information, does he require a referral to the renal team? The answer is no, but given his age, renal function and diabetes, then he needs close monitoring and careful treatment of his renal function, blood pressure and blood sugars. And we should consider referring him early if his EGFR declines further or his ACR starts to rise. Question 4. Harry is 70 with an EGFR of 29 and an ACR of 3, giving him CKD G4A2. His 5-year KFRE score is 4.6%. How often, as a minimum, does he need his renal function monitoring? The answer is twice a year, but if his renal function is deteriorating or he has other risk factors, then this will need to be monitored more frequently. How did you do? Thank you all for listening today. I hope that you found this podcast helpful and that you've learned a few extra nuggets of information. As always, all of the links to the resources I've mentioned will be in the podcast notes at GPnotebook.com. And we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. Right, I'm off to have fun by working out my risk of needing dialysis with the kidney failure risk equation. Goodbye.
Bye-bye.